Good day, folks. Aaron Sale here, the creator and one of the lead faculty for the CASTED emergency course. I want to thank you very much for signing up for one of our upcoming courses. And I want to just walk you through with this video a little bit of an intro into where the course came from, how we're going to be able to help you on your next shift, and talked about some of these important orthopedic principles. So the course, I promise you, will change your practice of emerge orthopedics. What we want to do is we want you to get these practical tips. It's totally a high yield course focused on what you need to know on your next shift. We don't want you to memorize Emerge Ortho. We want you to understand it. And where did this concept come from? I'll tell you. So I'm a full-time Emerge doc. Certainly started out my career that way. I spent a fair bit of time teaching now, but primarily in the beginning, for over 25 years now, I've worked in Emerge at North York General Hospital, the only hospital I've worked at as an Emerge physician. It's a great hospital, community teaching hospital in Toronto, in Canada. Tons of adults, tons of kids. Busy place for sure. And my interest was always orthopedics. That was an interest of mine in medical school. I realized I didn't want to do it, but I carried that interest forward through my Emerge time. And with that interest, about 15 years ago, so after 12 years of full-time Emerge, 20 shifts a month, I'd done like 2,000 shifts in Emerge. Felt really comfortable with the orthopedic side. The orthopods, orthopedic surgeons at our hospital said, do you want to run a minor fracture clinic? So I started this minor fracture clinic, seeing patients on my own, but I had access to orthopedic surgeons if I had questions. They would come and tell me things. I would see cases and follow up. And through this experience, I was like, whoa, I didn't know anything about Emerge Ortho. I learned so much from the surgeons. Added to that is that the last 5 years now, 1 day a week, I go to the operating room to assist on the ortho trauma cases. So we don't have orthopedic residents in our hospital. The Emerge docs do all the reductions. If we need something to be seen surgically, the surgeons do it, and they have assistants in the OR. And I just go and work as an assistant 1 day a week. Why? Not because I want to be a surgeon, but because I want to learn from the surgeons. What we do in Emerge, what helps, what doesn't help, what are like subtle cases, what are great pickups, great reductions in Emerge. All of these things I get to see and follow up and see how it's managed operatively, and then try to take those pearls back when we teach. And really the goal is to try to help us break down how we think about Emerge Ortho, because a problem is, like a lot of ortho is fairly obvious, they got a nasty fracture, but if the x-ray is negative, we often just go, it's just a soft tissue injury. And this is how we miss things. And then if there is, in fact, a fracture, we want to be able to dig a little deeper. If there is, in fact, a fracture, we want to know who needs to see ortho and when. So there's a lot of things we want to think about. But what we need to do is rethink Emerge Ortho. The other faculty who teaches with me, the lead faculty, is Dr. Matt DiStefano. Matt's an exceptional Emerge physician who works up in Collingwood, Ontario. It's a very busy rural hospital because of its proximity to the ski hills. So they see a ton of MSK volume. And Matt also has worked with the orthopedic surgeons, and he's actually done thousands of cases in the OR with his surgeons as a lead assistant, and actually functions at the level really of a senior resident in orthopedics. That's the depth of his knowledge in this. So what our goals are when we teach the course, when we lead these courses, it's either Matt or myself, or sometimes both of us that will lead them. The purpose of it is to actually help you be better on your next shift. That's all that our clinical focus is. When we do the hands-on part, we also have other experts in Emerge Orthopedics. We have other physicians that get involved. We also have other orthopedic technologists who have tons of experience in doing this, and they help in teaching the course as well. What we want to tell you, though, is that these principles, these pearls, come from the orthopedic surgeons, and it's our thanks for the surgeons. These are the 9 orthopedic surgeons I work with at North York General who teach us tons. And this is where the course came from. Luckily, I also work at a hospital, North York General Hospital, which has a real interest in medical education. So acquiring the knowledge at the hospital just made it natural to think about having a course for it. And then the other thing that's really helped in understanding it is actually just teaching the course. And we've given the course hundreds of times to thousands of participants over half a dozen countries around the world. And really what the purpose of the course is, strictly, it's to help you on your next shift. Emerge Ortho is a high volume of what we do, and it'll be great if we could actually manage these patients optimally. Not call ortho for every fracture, but also not miss things, right? And have better confidence in what we're doing. And this will increase our enjoyment of our work. So how do we do it? So the courses are broken down into into three components essentially. So the first component is basically case-based. So we just go case after case after case around, let's say, hand injuries or carpal injuries or wrist injuries. We work our way all the way up to the clavicle and then go from the hip down to the foot. So when we're talking about hand injuries, or here in this case wrist injuries, what do? We'll show you the spectrum of injury. We'll show you adults, we'll show you peds. We'll show you what's common, so-called Colles type fractures of the distal radius, what's commonly missed. 25 or 30% of distal radius fractures in adults are not Colles fractures. So we don't like the eponyms. We want you to understand what you're doing, right? Missed reductions are a problem sometimes. Not doing a proper reduction, not molding properly. All these things will highlight through cases how these things are either commonly missed, or commonly mismanaged. Then after we do the cases around wrist, we'll walk you through demonstrations. We'll walk you through a reduction. We'll walk you through immobilization techniques. Here's Oleg putting on an ulnar gutter in one of our demos. And you'll see how it's done, and then you'll get a chance to practice. So this is what would happen pre-COVID. We would just all be together, and we would practice. And when you're practicing, what would happen? One of us as faculty would come around and look at the splint that you're putting on. We'll see how you put your hands when you're molding. And then we'll put our hands on the splint and we'll mold it. And your partner will tell you if you're molding hard enough or not. You got to push a little harder. You got to push down a little bit. You'll put your hands back on until your partner confirms that's what you're doing. And that's what we did for hundreds of courses. And it really was actually very well received. And we're grateful to our mentors who taught us so that we have the opportunity to teach others. Of course, COVID has affected this somewhat, so you can see from those pictures it would not be reasonable to try to do the hands-on component now. What we do now is we use an online platform, and what we're doing with some of the courses now, if it's not safe to meet in person, we are just doing the pre-course. We're doing the online part. We're doing the online component. We're doing the cases online. So we do the cases online, we do the demonstrations online, and then when it's safe to meet, it could be a few months down the road, we will appropriately distance and we'll meet in person. If it's safe to do it all at once, we'll do it all together. It's not a problem. But we'll do it safe, and we'll provide you with the same exceptional learning opportunity. We've done a number of courses online already, and they've been as well received as our in-person courses. So we promise you an exceptional learning experience, whether it starts out the traditional way of being in person for the entire course, or whether it starts out online with a delayed subsequent course. And also now, because of this, we're actually able to do international courses online only. So we don't actually have the in-person component to it, but you can still get a ton of cases, a ton of demos, and even that, I'm certain, will help you on your next shift. But our real goal is to help you rethink Emerge Orthopedics. To rethink it, we need to use the adult education, adult learning method of spaced repetition. And this is why we have this pre-course video. Because if we want you to think about things differently, we just can't hit you with it on one weekend. You have to understand it a bit beforehand. The video's about 55 or 60 minutes, and as you go through this, you can do it in pieces, no problem. Another little tips to it, if you see a box with a page number, with a number in the top right, that's the page number. Sometimes it'll say sup-3, that would mean page 3 of the supplement. But what we want you to do is, you can hit a space bar and you can stop at any point. You can do it in pieces. You can just watch a half hour now and half hour later. You can watch it again a week before the course. All these things will help you understand the principles, because we need to think about Emerge Ortho differently. If somebody asked after my first 2,000 shifts, I'm not a big fan of algorithms, but if one said, here's give me your Emerge Ortho algorithm, it'd be like this. Somebody comes in with some sort of musculoskeletal injury, and we'll take an x-ray. And if it's positive, they have a fracture or a dislocation. If it's negative, they have a soft tissue injury. Unless they had snuff box tenderness, and then would say, you have a clinical scaphoid fracture. And this seemed to work. But you can see, I'll tell you one thing, though, when you look again here, page 5 in your manual, that's the number is the top right. Ortho is about 10 or 20% of Emerge visits. It's a huge volume of what we do, relatively speaking. But when we look at things that ended up with either a complaint or a lawsuit, MSK or orthopedic injuries are disproportionately represented. They're only about 15% of visits, but they're like 25 to 40% of lawsuits. And why is that? It's because we're obviously not doing something right. So we got to figure out how to be better. And when you look at these complaints or lawsuits, 70% of the time, the diagnosis was missed in Emerge. So we need to be better diagnostically. 20% of the time, the diagnosis was made, but it wasn't managed properly. So we need to be better with our emerge management skills. And 10% of the time, it's disposition. It's how the patients were followed up, the advice we gave them. We need to be sharper with that as well. And what I think the problem is for a lot of it is for this whole lot of this is that we spend too much time focused on the X-ray and don't do proper assessments. Imagine if we had a patient with chest pain. Said, oh, I'll just do a similar algorithm for chest pain. We'll just do some tests, an ECG to troponin. And if it's positive, they have an acute coronary syndrome. And if it's negative, they got chest pain, NYD, not yet diagnosed. Of course, this is a ridiculous algorithm. And what I'm going to suggest is the algorithm that I use for 2,000 shifts is equally ridiculous. So we want you to rethink ED ortho. We want you to have improved diagnostic skills so that when you see the patient with a normal ankle x-ray, if you've done a history and a physical, you'll predict, and this is the exact same patient, they're actually a surgical case. They're way more serious despite the normal x-rays. And guess what? The keys to an emerge ortho diagnosis are nothing different than we do every shift for headache and chest pain and abdominal pain. It's history plus physical plus or minus a test. Well, we way over rely on the test, and it's a problem. And it's actually, again, we want to break this habit. So let's give you some cases. Here's a 26-year-old. He was vacationing, injured his wrist. X-rays were done. He's told he has a fracture. Come back to Toronto. So when he comes back to Toronto to get assessed, he gets repeat x-rays done. So you can put pause if you want. Just hit the space bar and pause. Take a look at the x-ray and decide what you want. The emerge doc who saw the case diagnosed him as an ulnar styloid fracture. He was already in a splint. It was well-fitting, neurovascularly intact. Follow up with me in the minor fracture clinic. When he comes back to see me in the clinic, I say, oh, sir, what happened to you? And then I basically just bite my tongue. Just let him talk. And he says, he was inebriated. He got a little hammered at an all-inclusive place. He late at night, he goes to the balcony basically to throw up. And then he falls off the balcony. The emerge chart said foosh. This guy fell off a balcony. That's not foosh. That's foosh. That's a hell of a fall. He was on the second floor, right? He fell. I said, what happened to you then? He goes, oh, it was just my wrist. When I got up, my wrist was way down. And my wrist moved as soon as I got up. It's like, oh my God. He goes, then what? He goes, then I went to a hospital. They took an x-ray. Then two people pulled one way, two were on the other side. They put a cast on me, took another x-ray and said, you better go back home. And now if you look at the same x-ray you saw before, again, you can pause if you want to spend a bit more time, but you'll start to appreciate there's more going on here. There's the two with plaster. So these were post-reduction. These are the films that he brought with him from his vacation spot. He said his wrist moved. Well, let's pay more attention to this. That's the capitate that sit in the lunate. When we go and when we're during the course, we'll talk about perilunate dislocations. But also that scaphoid should be one piece, not two. Post-reduction, take a look. The scaphoid's still in two pieces. The capitate and the lunate are not lined up. He doesn't need to come back and see me in the minor fracture clinic. What does this guy need to do? This guy needs to go and see a surgeon. But this is missed and emerge. It's the importance of a history. So you need to know what happened. If someone was in a head-on collision, you pick up the chart, head-on collision, you ask a million questions. Was this your head-on collision? Or was this your head-on collision? You want to know the forces that were involved. It's not different if they fell off a bike or if they had a fall in their outstretched hand. You want to know the forces that were involved, the mechanism of injury. Did they fall in their outstretched hand or fall in the back of their hand? They injured their ankle. Was it an inversion injury? Was it external rotation? Did they axially load? These are all different mechanisms that we'll detail when we go through these specific areas in the cases. What happened afterwards? I was playing soccer. I hurt my knee. I kept playing for another hour, and the next day my knee was sore and swollen. Well, you probably didn't tear your ACL. There are things that are happening. You didn't have a significant fracture. Their events afterwards are very helpful. But just ask the question. It's more than just looking at the x-ray. You have to appreciate who that injury or that force occurred to. The patient's age, right? Again, if you're young, you got weak bone. That's how we think about this. So kids are more likely to fracture, but don't forget elderly have weaker bone because of osteoporosis. What's their past medical history? If they just have a bit of hip pain, we're often not worried about it, except for if they got hip pain and they're on a disease-modifying drug because they got rheumatoid arthritis, or they have lupus, or they have HIV, right? Anything that may affect their immune system, that little bit of hip pain may be a septic joint, so now your pre-test probability changes. medications they're on, if they're on immunosuppressants, if they're long-standing diabetic, whatever, if they've been recently put on antibiotics for some other reason. Again, infection may not present the same way. Have they had previous injury? You examine someone's knee and, whoa, it feels like their ACL's loose. Well, maybe they previously injured their ACL. Or you examine someone's knee and you're really good and you examine the opposite side and they both feel the same. But the guy tells you, you know what, I actually injured my other ACL, never had it fixed. So maybe what? Guess what? Maybe those are both abnormal. You need to know about previous injury. And vocation and recreation is helpful just to know the demands that they need to get back to. It won't change a lot in terms of what we're going to manage in the emergency department, but it's important to know how important it is that they get back to optimal state and recover fully. So the more physically demanding they are, either because of vocation or recreation, the more precise they need to be in terms of their recovery. So remember, though, there's it's kind of not a very common saying but fractures occur because of two reasons. Either you put an abnormal force on normal bone, so a 26-year-old guy falls off balcony and breaks his wrist, or you put a normal force on abnormal bone. 86-year-old falls from a standing height and shatters wrist. And when we think of abnormal bone, we often think of just kids because they got open growth plates and they have soft bone. But don't forget as well that older patients have abnormal bone. So just from an age point of view, start to divide them up, not just kids versus adults, but kids versus young adults versus older adults. Whatever you use the number as old, but just understand that once you get past 50, 60, 70, more likely to have osteoporosis. It doesn't take as much to cause a fracture. People who are 70 or 80 can break their hip without falling. Why? Because they just rotate, they turn, they have a long osteoporotic bone, and if there's an arthritic hip, guess what? The joint doesn't give way, and the force comes out the bone. So a lot of these older patients with hip fractures, if you actually ask them, they had the fracture while they were standing and rotated. They fell because of the pain. Now, most hip fractures are because of the fall, but a lot of them actually occur while they're standing. And again, it's another concept to understand. It's just what's the quality of bone? What's the patient who has this force? Keep this in mind. Super important as you go and assess patients. So that's the history that's important. What about the physical exam? We actually need to, do a physical exam. You need to touch patients. I'll tell you why it's important. Because none of us want to cause pain. So we just, you fell, you hurt your wrist. Okay, I'll just take an x-ray of your wrist and we'll send them on. But it's really important for a few things. So orthopedic surgeons talk about limb wound. Think of life-threatening injuries first, then limb-threatening. Then you can go look at the wound or the injury or whatever. These are all cases that we've seen. Like this is a 4-year-old girl with a supracondylar fracture of her elbow. This is a nasty elbow fracture, right? It's very easy to be distracted by this wound and just pick up the phone and as an emerge physician want to call an orthopedic surgeon. But you got to make sure there's nothing life-threatening. Head, neck, chest, abdo, pelvis. You got to make sure there's nothing limb-threatening. Go past the injury. Make sure the patient's nerve actually intact. Now you can go back and assess the wound. When you're looking at an ankle or a wrist or a patient's knee, a nice little mnemonic is look, feel, move. It's important we look. It's important we look down to the skin the first time we lay eyes on a patient, because here's a 91-year-old lady fall on outstretched hand. Clearly she needs an x-ray. It's totally appropriate that it was immobilized by EMS before she comes. It's an isolated wrist injury. But when you take her splint off, you see she's got a ring on her finger and she's open on the ulnar side. You need to lift the arm up and make sure on the volar side there's nothing going on. This is super important. Sometimes on the volar side, the skin is pinched. And if there's a little pinch, you see that there's a pinch in the skin, that's because it's hooked on the soft tissue. If you leave that and don't relieve that pinch, what happens is it disproportionately swells at that site. And if it swells at that site, disproportionately, it's more likely to become secondarily opened. And all you need to do is see that little pinched soft tissue, try to pull on it and to release it. And now the swelling is more diffuse. It's less likely to be secondarily opened. But you need to look the first time you lay eyes on the patient before you send him down to x-ray. Look circumferentially around. It's totally appropriate. EMS puts him in a splint. It's really important you look down to skin, because if it's open, the whole timeline changes. As well, when you look, you need to compare to the opposite side. A patient, when they have an extremity injury, they almost always have another extremity. Go look at it. And if you see somebody who's 26 who injured their ankle and they have a big, sore, swollen ankle, something bad happened to their ankle. Right? So these are just things that you need to keep in mind. So it's super important to compare to the opposite side. One of the things that we don't do well, I'll tell you, because I know I didn't do it very well is we don't actually touch patients we don't want to cause them pain. If somebody injured their wrist, my wrist exam, my first 2,000 shifts, the one data point that changed things was, do you have snuff box tenderness? And then I started working in the fracture clinic, and the patients and the surgeons taught me a ton. And I started making diagnoses I never made my first 2,000 shifts. And now I go back to emerge, my wrist exam is way better. Why? Because if somebody's fallen on their outstretched hand, okay, distal radius scaphoid, that was kind of it. That's what I thought about. But guess what? There are all these other possibilities. There's a whole bunch of diagnostic possibilities, and what drives you there is the physical exam, is the point of maximal tenderness. Try to be as precise as you can be. So try to focus and try to put a finger where it hurts the most, because then underneath your finger is the source of their pain. And if they have multiple sources, good, that's fine. Just ask which is the most painful area. Don't dismiss the other ones, because there could be pathology under there, but try to be focused on it. It's an important concept, as opposed to just touching the snuff box like I did. When we talk about point of maximal tenderness, here's another important aspect. Here's a 30-year-old guy was rollerblading, fell, injured his right elbow. That's what he complained about. So his x-rays are done. When I go see him and emerge, I just grab his other arm as well. I examine his left wrist and see if it's sore. And he's actually sore in his left wrist as well. So we can see he's got a radial neck fracture. He's got an effusion. We'll go through this in the elbow section. But on his left wrist, I sent him back for x-rays. Why? And there's a little chip there. It's exactly where he's tender. He's got a triquetral chip fracture on the left side. He didn't know that he had it, and he wasn't sent for x-rays for it initially. And if all I did is look at his x-rays and said, yes, it was sore and didn't complete it. It's the importance of point of maximal tenderness. Just make sure there isn't something else. A quick little screening exam is also, you don't have to examine every other possible joint. You just have, you don't have to x-ray them rather. You need to examine them. A 77-year-old lady I saw in emerge fell down a few stairs in tremendous pain because she totally destroyed her proximal humerus. She's in a ton of pain. You know, we got on her right away to try to manage her pain. She's really quite uncomfortable. But guess what? Just complete her exam on her upper extremity. So again, make sure there's nothing life-threatening, which there wasn't, thankfully, right? But also on her left arm, her elbow was quite sore. Not as bad as her shoulder, but an x-ray showed what? That she had an olecranon fracture. And then her treatment is both treating the surgery for the shoulder as well as for the elbow. So don't forget these. These are super helpful. It's the point of maximal tenderness. Don't just find a point of tenderness and stop. It needs to be the point of maximal tenderness. And don't forget to move people. It's easy to miss these operative soft tissue injuries if we don't move them. It's easy to miss subtle dislocations or subluxations if we don't recognize them, right? And it's the importance of trying to move patients. It can be done gently, but here's a 70-year-old gentleman who slipped off a ladder. His x-ray, he injured his ankle. He limps into emerge. X-rays are done. X-rays are read as negative, maybe an ankle sprain, some soft tissue swelling. The patient was provided with an air stirrup, right, and followed up in the clinic. But the tech who put the air stirrup on went back and assessed the patient, and he's got a lot of swelling in the area of his Achilles in the back. We'll talk about this during ankle x-rays, but you know there's a triangle back there you're supposed to look for. But anyways, the soft tissue triangle is obliterated, and what does he have? He's got a ruptured Achilles. That's easy to miss if we just look at the x-ray first and then tell the patient what's wrong. Because if we start with the x-ray and it's normal, quote normal, what do? We don't need a full history. We don't need a full physical. We just shortchange them. And this is where the mistakes occur. So x-rays are a good test, but they're not perfect. You need to separate your faith in the x-ray. So these are the keys to an emerge ortho diagnosis. It's the details of the injury, right? What were the forces? What was the mechanism? What were the events afterwards? What are the patient factors? What is the patient to whom those forces were applied? And what were the effects of it? What's the physical exam? Look, feel, move. No one's asking you to do the 20 tests for the shoulder that exists for a sports medicine clinic, but there is a focused physical exam for each joint that we will go through in the course. And then you bring the x-ray into it. Okay, sometimes when you do a physical exam, you'll look, you'll feel, and you'll go, oh, I wonder if you might have a little fracture, proximal humerus. You may send them to x-ray, but when they come back from x-ray, if the x-ray is negative, don't forget you haven't moved them. If you see a bad proximal humerus fracture, of course, you don't have to crank on the arm and move it, right? But you may want to delay part of your physical exam till after the test is done. And now what happens is when the test is done, treat this test like any other test. So if somebody had a normal wrist x-ray in the past, an adult closed growth plate, and they had no snuff box tenderness, the default diagnosis for me was soft tissue injury of the wrist. But working in the fracture clinic, seeing all these cases, it's totally taught me that it's just a test. Right? What I need to know is, A, what is the story? What is their exam? And then I can talk about how to interpret the test. And what this is called is Bayesian theorem. I don't want to get too caught up in stats. I'm not really a stats guy as such. But this is what we do with every test. You do an ECG, you do a troponin, a CT head, you do a wrist x-ray. What you need to have is a pre-test probability. You need to know how good the test is. Then you can develop a post-test probability, and this affects our management. So if you took 100 patients, we're looking at something called a likelihood ratio. If you took 100 patients that emerged that had an injury and they had a negative x-ray, there's probably about a 5% risk that 5% of those 100 patients actually have a fracture that's just not seen on x-ray. So how do we use this theorem? Well, this nomogram is, basically to think of the patient. So if it's a 25-year-old patient, imagine it's a 25-year-old guy, and his story is, he just 4 or 5 days ago, he just turned around pretty quickly and he whacked his wrist against the door frame. So his radial styloid hit against the door frame. It still hurts 5-6 days later. He comes into your emerge department. So if he comes in because he's got a fair bit of pain, you don't think he's got a fracture, but you'll probably do an x-ray. And your pretest probability for a 25-year-old with good pain, with good bone, with that mechanism, is probably 10%. And if his x-ray is negative, and you see that, then he's got like a 0.6% chance of having a fracture after the x-ray is done. But if it's a 68-year-old lady who is playing tennis, she goes for a drop shot, she falls, and she has pain in her wrist. And when she has pain in her wrist right away, it's sore, it's swollen. She comes in a couple hours later, she's examined, she's tender, swollen right over her distal radius. The only part of her wrist that's sore is the distal radius itself. After that mechanism, with that age patient, with that physical exam, her pretest probability for fracture is probably 90%. She has a negative wrist x-ray, but after the x-ray is done, when we use this Fagan nomogram, her post-test probability is 30%. There is a 50 times difference in both of these patients, both of whom have a normal x-ray. There's a 50 times difference in their post-test probability for a fracture. Based on what? It's based on history and physical. They both have a negative test. So you need to know these patient factors. You need to know the injury factors, right? When you interpret a test. In fact, this is a 68-year-old lady who fell after playing tennis, tender distal radius. And the emerge doc who saw her, she's better than I was my first 2,000 shifts. How do I know that? Because she said to the patient, you might have a fracture or maybe it's a soft tissue injury. We don't know. Immobilized her and said in a week, if you're feeling great, it's not a fracture because a fracture doesn't heal in a week. But if it's still sore, come back to the fracture clinic. She was given an appointment. She came back to see me 1 week later. When she comes back 1 week later, she's still tender distal radius. I'm like, you probably have a fracture. We put her in a splint for comfort. She can take it out for bathing. She comes back 3 weeks after that. So now 4 weeks after injury, we repeat the x-rays. And again, if anytime you want to spend a little more time looking at an x-ray, just hit the space bar button and you can pause the video. But when you look at this x-ray and follow up, guess what? She now has a healing fracture, diagnosed by the first emerge doc before the x-rays were even done. And I'll tell you, I worked 2,000 shifts in the fracture clinic. 2,000 shifts in emerge, right? My first 12 years, I never once diagnosed an adult with an occult distal radius fracture. I diagnosed a ton of people with occult scaphoids. And when I follow up now in the minor fracture clinic, I see way more patients with adults with occult distal radius than they do have an occult scaphoid fracture. So what it means is I missed every one of them. Now, the natural history of an occult distal radius fracture, it's no big deal. If you can't see it on x-ray, it's going to heal. It just needs time. It's not a big deal. But why is it important? It's important because we need to understand that an x-ray is a good test, but it's not perfect. So if you saw an x-ray of a hip in a patient that you had a high pretest probability for, that's not good enough, because if they got up and walked on that, they're more likely to have problems. If you suspected a tibial plateau fracture in somebody and their x-rays are negative, if you were really worried, they might need to have more advanced imaging. If you had an injury where it doesn't really, you can treat them and they won't get harm and they can have follow-up, then that would be totally fine. That's how it affects your management. So if you see patients with suspected occult fractures, they need one of two things. They either need more tests, like advanced imaging if you're really worried, right? And they may get harmed by waiting, or they just need more time. They need a serial assessment. And then if they're still sore and there's still clinical concern, they can have a repeat x-ray and perhaps delayed advanced imaging. But this is how we decide. Don't be afraid that every occult fracture is bad, but don't be afraid that every normal x-ray is good as well. You need to overlay your clinical probability, your pre-test probability. Because really, at the end of the day, these are all just tests. And just like when we see a patient with a normal ECG, that's a good starting point. It's not good enough. If somebody has a normal MSK x-ray, that's good. That's a good starting point. It's not enough. You need to treat them equivalently. And in the supplement that you have, if you go on to page 3, we talk about this mnemonic. If you run this mnemonic 5, 6, 8 times, it'll start to come, it'll sing true to you on your next shifts, right? It'll just become true. What you need to think about is that you're not scared of a normal ECG. Don't be scared of a normal x-ray. And this will just help you think about some other diagnostic possibilities while you're there with the patient and with this normal x-ray that, okay, yeah, I'm not worried about these. So let's walk through the mnemonic. S is septic. And these are all detailed in the supplement. But you can have a septic joint. Think about the patient. Think about their injury. Think about whether infection may be causing this. Compartment syndrome. Rare injury, commonly missed in emerge, but start to feel compartments normally. We all write neurovascular intact on a chart. Write compartments neurovascular. Start to feel it normally. You'll start to get good habits of just feeling compartments. You'll recognize that young adult males have thick compartments because they have more muscle. Females have more soft tissue compliance. They're less likely to have compartment syndrome. Older patients lose muscle bulk. They're less likely to have a compartment syndrome. Abuse. We're not good at picking it up, but this could be violence on the base of against children, domestic violence. It could be against elderly. But think of it, right? And just give it consideration. We're not very good at picking it up, and there is evidence that if we miss it and emerge, which is usually what happens, that patients will come back and be victims of even greater violence. So it's important to try to pick this up and keep considerate of it. RE, 2 letters, 2 things to think about. Think about referred pain. Somebody could have knee pain, but it's referred from the hip. But if they had knee pain and the knee actually wasn't the source of the pain, when you touch the knee, it's not going to be sore. So this is the importance of physical exam. It ties back into what we're talking about. The purpose of the physical is to confirm what you think on history. Think as well that the report might be false, that the radiologist's report, maybe they missed the abnormality. And radiologists, I used to think, never missed anything. And over time, I'm realizing that they do miss things. And in fact, of course, if I was a radiologist, or emerge docs everywhere would have cases that I missed. So it's not about criticizing the radiologist. Sometimes it's our fault. We write x-ray body, rule out pathology, rule out fracture. We don't give them a lot of help as to where the injury is or what the story is. That's on us. But we have a history. We have a physical exam. We have our eyes on the report. And there are studies done. If there is an abnormality on the x-ray report, and of all, on the image rather, if there's an abnormality on the test that we do in emerge, about 80% of tests we do in emerge, imaging tests, are normal. 20% are abnormal. Right? The radiologists miss about 4% of the 20%. That's 1 in 5 abnormalities. That's about a 20% miss rate, right? And that's pretty significant. But if you think what a radiologist has to read in terms of they've got to read like nuclear medicine and ultrasound and CT and X-ray and plain films from kids in community hospitals all the way up to like elderly people over 100 years of age, it's amazing what they have to know, the breadth of what they need to know. So just have a little healthy dose of skepticism when you see the radiologist report and try to look at the films yourself. It's super important. D is a dislocation or a subluxation. So this person may have injured their knee, but if the knee dislocated, there's a 50% chance it went back in. You can have a subluxation, which is a partial dislocation, and the x-rays can be normal. They could have an operative soft tissue injury, so it varies by joint, but if we're talking about an ankle, an Achilles rupture may be treated non-operatively, but there's a specific treatment we need to do in emerge. Many Achilles still are treated operatively depending on surgeons. If you had a knee injury, a patient had a knee injury, they could have a quads rupture, a patellar tendon rupture. Technically, these are, yes, soft tissue injuries, but they are operative soft tissue injuries. So just give consideration to these as possibilities. If you had an elbow injury, it could be a distal biceps rupture or a triceps rupture. Again, operative soft tissue injuries that are commonly missed, generally because we overlie on the x-ray and we don't move patients. The themes will come out after case after case after case. We'll see tons of cases, almost a couple of hundred cases during the course. And you'll see how these themes will just rise to the top. And what we want you to do then is understand the principles. And F is an occult fracture. So don't be paralyzed by this assessment. Feel empowered by it, that you now realize, oh, there's all these things. And I thought about them and they're not there. And then if you're not worried, you can just dismiss the patient as some sort of, not otherwise specified soft tissue injury. However you want to figure it out, however you want to diagnose them. But at least you've thought about these and you're less likely to miss them. So the keys to management, again, what is the history? What's the physical? Now the x-ray becomes super helpful because here's a 68-year-old lady with an occult distal radius fracture. How do I manage that? A 22-year-old with a distal radius fracture, a 46-year-old who shattered his distal radius. And of course, you'll have at least 2 views and often 3 that'll help you. But the x-ray becomes super important in how to manage these cases. And think of it less as a diagnostic tool and more as a management tool. See, every time we call ortho about a case, they say, what's the x-ray show? Because they want to know, actually, how to manage the case. But then what we do is we get attached to the x-ray, but we try to use it diagnostically. And this is also part of the disconnect. So try to distance yourself from being so connected to the x-ray diagnostically, but when it comes time to management, the x-ray is pretty helpful. There's all these classification systems. This is the AO classification system for ankles. There's 9 different categories you see here. And the good news is the top 6 actually have a drop-down menu. This is useless from an emerge point of view. We don't want to worry about this. What we want is a simple checklist for fracture severity. We want to know, is it a good fracture or a bad fracture? And there are essentially 4 things that you're going to start to look at when you diagnose a patient with a fracture, right? That how severe is this fracture? So there are patient factors we'll talk about separately, but essentially from an x-ray point of view, we're often satisfied as an emerge physician, oh, I saw a fracture. Good. Now ask a few more questions. Is it comminuted? Comminuted means more than 2 pieces. Does the fracture go into the joint, so-called interarticular? If the joint's involved, that's more concerning. Did the fracture shift or not? Because when it shifted, it tore soft tissue. And is the fracture oblique or spiral in its orientation? So a fracture can be transverse. That's usually high energy. An oblique fracture is kind of a shear, like a diagonal. And what that means is it got pushed off usually. And if it's a spiral fracture, it means a rotational force. So you might know what each of these 4 words mean. What's important is understanding the clinical implication of them. Again, it's the understanding and not memorizing what the definitions are, understanding what it means. So the more pieces a fracture is in, the harder it is to hold together, the less stable the fracture is. If a fracture goes into the joint, what it means is at where the fracture exits, there's articular cartilage that covers the bone. And if that fracture is not anatomically aligned, now the fracture may heal with a step deformity in the articular cartilage, which over time leads to arthritis. So we're much more worried about cases that go into a joint because long-term it can cause much more harm. So you're going to train your eye to look for fractures that go in the joint, and we'll show you case after case after case during the course. If the fracture shifted or not, this is an important one that we often don't realize as emerge physicians. Orthopedic surgeons talk about that a fracture is a soft tissue injury that just happens to involve the bone. As emerge docs, the fracture is a bony injury, but really what drives it is the soft tissues. So a couple of things. If you had a patient with a distal radius fracture, right, that was displaced significantly, a nice 2-part fracture, but it was displaced and we reduced it. The tendency of the fracture is to go back where it came from. So the fact that we reduced it makes it less stable. The fact that it shifted a lot initially means that soft tissue envelope was damaged. It's less stable, more likely to shift. As well, because the soft tissues were injured, it will take much longer to recover. So a 25-year-old who, let's say, has a significantly displaced distal radius fracture, even if it's treated non-operatively, it gets watched weekly, it gets held, it may take 4, 6, 9 months before their wrist feels like normal, sometimes longer. But if you have a 25-year-old who has an undisplaced distal radius fracture, They have good quality bone. That fracture's not likely to shift. They can get x-rayed a couple of times, but they'll be fine. It won't take as long to heal because there wasn't as much soft tissue damage that was done. It's less likely to shift because the soft tissue is intact. And that patient may be in a cast for a month, but another month or so after, because it never shifted, they might be back to activities. So short-term and long-term, the complications are greater the more soft tissue injury there is. So just keep this in mind. Lining up the bones doesn't mean things are perfect, right? It all depends upon how stable it is. It all depends upon the soft tissue that's involved. And then oblique spiral is another important one that we often think about. Oh, it tells you about the force. So that's a retrospective historical thing. But what helps us, though, what it really helps is going forward. And this is, again, not so appreciated. But just imagine there's a kid on a slide. So here's your little kid. He climbs up the ladder and he's on the top of the slide. If he's on the top of the slide, on the platform, on that red platform, and somebody pulls down, that's like a transverse fracture. If it's a transverse fracture and a muscle pulls on it, the kid doesn't move. The bone doesn't move if it's good quality bone. Right? Put the kid on the top of the slide, on the oblique, on the sloped part of it, and now somebody pulls straight down. So imagine an oblique or a spiral fracture and a muscle pulls. When the muscle contracts, when the muscle pulls, the kid is sliding down the slide. The bone is more likely to shift. So yes, oblique spiral tells us about the force that caused it, but it also tells us about its likelihood to shift. And it's an important thing to start looking for. And again, during the course, we'll show you case after case after case. We're just recognizing it's oblique, or recognizing it goes in the joint, or recognizing it's multiple pieces gives you more concern. So these are x-ray factors that'll tell you about. What you also want to add is patient factors. So, what is the patient like? You want to know, what was the soft tissue? Is it open? Is it closed? Is there a risk of compartment syndrome? All of these things also contribute to it. And what this helps you do is risk stratify. And when we talk about risk stratify, again, this is on the supplement in page 8, you want to add the personality of the fracture to the personality of the patient. Is it a good versus bad checklist? The actual injury, bring the soft tissue into it. Add the personality of the patient. What is their age? If they're older, they have a poorer quality bone, more likely to shift. What is their compliance? A young adult male may not be so compliant. So it may mean you have to be careful about that in terms of how you manage them. What are their physical demands, vocationally, recreationally? What are their comorbidities? If they smoke, the risk of non-union goes up. If they've got diabetes, if they've got poor sensation in their feet, a relatively minor foot fracture can be a real issue. If you're a 10-year-old kid, you can remodel the bone. So if it's a distal radius fracture, a little dorsally or volarly angulated, let's say, right? And they're 5 years of age, let's say, they got more room for remodeling. All these are things that come into play. And what we're going to do is go beyond just looking at a fracture. And this, guess what? It takes time. So it takes time to understand it. That's why you're getting the pre-course video. This is why you're going through it. And you'll see how these factors in real cases actually make a difference. Then you'll understand, and this is the whole spaced repetition. You'll see this over time. Once you have a patient with a fracture, you start to understand, you're going to start to stratify them. Now, how do we manage that fracture in the emergency department? And there are two very simple goals that orthopedic surgeons have. It's obtain a reduction and maintain a reduction. And every time you see a patient with a fracture, we want you to say the phrase, obtain and maintain. Obtain asks, is the position acceptable? Maintain asks, will the fracture shift with activities of daily living? Is it a stable fracture? And this is how we're going to help you improve your emerge procedural skills. Because by asking these questions, you'll understand what needs to be done. And we talked about, how cases are misdiagnosed because they're missed altogether. That's that history and physical. Don't over-rely on the x-ray. When we talk about mismanagement, that's a diagnosis is made, but it wasn't managed properly. We're going to help you improve your procedural skills. So not only will you be better at doing the reduction itself, which we'll walk you through, but knowing the reduction needs to be done. This is the 22-year-old with a distal radius fracture. Again, we'll always look at two views, not just one. But on this view, this fracture needs to be reduced. We'll walk you through that during the course as to why that needs to be done. And then once you say, okay, I need to do a reduction, or the patient has an injury, how do I immobilize them? There's all kinds of options. You can use plaster or fiberglass. You'll start to appreciate plaster is way easier to mold than fiberglass. If molding is important, if it's important to hold on to this, right, then you need to mold it. And therefore, if molding is important, then plaster is by far preferred. These are plaster. These are rolls of fiberglass, rolls of plaster that you see. But we hardly ever use circumferential in our emerge department. And again, in our emerge, we do all the reductions. Ortho residents don't come down. We don't have ortho residents in our hospital. We basically do the reductions. And our surgeons want us to put them in very good splints, not use circumferential casts, because it causes more pain, more swelling at circumferential. Right? And even when they come back, they're going to be loose. They have to change the cast anyways. The splints are actually a much better way. We'll detail that. But we'll show you ways how to do it properly. For some fractures, they can be removable because they're stable injuries. Some you do nothing. They just have a presumed radial neck fracture. We may just give them a sling. And we may not do anything for it, even though. So there are many options that you need to choose from. And how do you decide? The decisions are made based on whether the fracture is stable or not. And stable means, will the fracture shift with activities of daily living? These are important management questions to ask about. So if the fracture is stable, means it's not going to shift with activities of daily living, it hurts, so they need some comfort. The patient needs to be protected. They can't go back to sport the next day because they have this fracture that needs time to heal. So they just need treatment that'll manage those two things, their comfort and their protection. If it's unstable, it could be grossly unstable, or it could be mildly unstable. If it's grossly unstable, typically the treatment is going to be surgical. Right? And most of the time we'll reduce them. There are a few exceptions we'll talk about during the course. For example, a bad supracondylar fracture in a child, we don't reduce those, we leave them. But otherwise, a tib fib, a femur fracture, even if they're badly displaced, it's good to reduce them to protect the soft tissues. Ankle fracture dislocations, we have to get on those pretty quickly to reduce the soft tissue complications, even though the definitive care is going to be surgical. So if they're grossly unstable, reduce if necessary for the most part, and then splint them and surgery. Talk to surgery and let them plan when they want to do it. If it's mildly unstable, the position, if the position is not acceptable, we'll reduce them. Right? If it's mildly unstable, typically we'll do the reduction. Again, there's a few exceptions where we wouldn't reduce them. And then if you reduce it and emerge, if it's a case that we should reduce, we want to mold it because the fracture might shift. And when you mold something, you need plaster on both sides of the fracture. If you're molding a patient with a distal radius fracture, you can't just put a dorsal slab or a volar slab. You need plaster on both sides. You need post-reduction films, and then you need close follow-up because the fracture might slip. It might hold its position, it might not, and you're going to start to stratify these patients. And this concept of obtain and maintain is super helpful in guiding us. And you'll answer the questions. Obtain, is the position acceptable? You'll say, yes, it is, in which case a reduction is not needed. You'll say, no, it's not acceptable, in which case a reduction should be done, either by you or you're going to talk to ortho, depending on the case. Right? Sometimes for obtain and maintain, you'll say, I don't know if the position's acceptable or not. And if that's the case, then at a reasonable hour, say between 7 a.m. and 11 p.m. or so, you can just call ortho and say, I got this patient with this fracture. Does it need a reduction? And if you have a specific question, they're more likely to give you a specific answer. Or you can choose to reduce it, and then you'll just follow up afterwards and find out if it really needed a reduction or not. So these are different ways that you can, again, grow your skills. Maintain asks, will the fracture shift with activities of daily living? And then you're going to start to go, it's stable, it's mildly unstable, it's grossly unstable. And again, if you're unsure, err on the side of caution. If you're not sure if it's stable or not, treat it as if it might shift. Right? And then you can figure this out. So we'll show you in cases how this works. So for example, here's a kid with a distal radius fracture. Again, if you wanted to hit the space buttons, a space bar, and just stop the video, you can take a closer look at this. But this is a buccal fracture of the distal radius. Ask yourself, every time you see a fracture, obtain and maintain, is this position acceptable? Yes, it's acceptable. It does not need a reduction. Okay, good. Now, will this fracture shift with activities of daily living? And if you're not sure, you can treat it as if it might and put plaster on both sides of the fracture and then mold it. But if you know that there are like at least 8 randomized controlled trials saying these buccal fractures don't need molding, they're not going to shift, they're stable injuries, then you can just treat this child with comfort and protection. That could be a volar slab, a dorsal slab, plaster, fiberglass, a removable splint. For stable injuries, it doesn't matter because molding is not important because the position is not going to change. Here's a young adult male with a bad tib fib fracture. Is this, again, every time you see a fracture, obtain and maintain. Obtain. Like long term, is this position acceptable? No, but in the emerge department, we really don't have to do much more than this. This has already been realigned to some degree, right? So this position would be acceptable short term, but certainly not acceptable long term. Maintain though, will this fracture shift? Well, clearly this fracture, if the patient were to walk on it, of course it would fall apart. So if it's grossly unstable, it's operative treatment. And this is how you guide it. If someone's going to need an operation to fix something at a reasonable hour, you call ortho. If it's open, if it's compartment syndrome, if it's other things, of course you call ortho any time of day. It becomes an emergency. But orthopedic cases that you think need an operation, but don't need it emergently, it's reasonable to talk to ortho if you can, so they can triage when they want to see the case. They can confirm your plan. They can try to see the patient sooner. But if we just sort of, took a patient that you thought needed an operation, you put them in a back slab follow-up in a week, sometimes the patient now is getting delayed time to get their treatment. We'll talk about how this can play a role. 22-year-old falls snowboarding. Look at this wrist. Look at their x-rays. These are the two x-rays. Obtain and maintain. Is this position acceptable? And we'll show you how to determine this in a 22-year-old. For distal radius fractures in adults, this is not acceptable position, so it needs to be reduced. And when you reduce it, right, will the fracture shift? Yeah, the tendency of the fracture is to go back to where it came from, so we put plaster on both sides of the fracture. And it needs to be connected plaster. It's not just like a sandwich with dorsal and volar plaster. It needs to be connected. So it wraps around the radial side. You can either do two separate slabs that touch each other, or we can show you with one slab. But in any event, this is how you're going to guide yourself. You do a post-reduction film, and then you have them closely followed up. But this is how you're going to start to get better disposition skills. Because here's an 11-year-old kid who injured his elbow. He's got a radial neck fracture. Right? You can, again, we'll go through this in detail during kids' elbow injuries. But the emerge doc who saw this, an excellent emerge doc, put him in a back slab, follow up with ortho in a week. Kid was seen on a Tuesday. The fracture surgeon's clinic was on Friday, so he gets seen the following Friday, 10 days later. Doesn't sound unreasonable. The kid's immobilized. Orthopedic surgeon shows me the case and says, "Can I show you something?" I said, "Sure." He goes, "You see that radial neck fracture? It's not in good position. It's pushed off." And he says, if you do the next x-ray, it'll never be better than this unless someone reduces it. It may be this way, or it may continue to shift. A follow-up x-ray that's done will never look better than when it left emerge unless somebody reduced it. So he says, if it stays in this position and doesn't improve, the kid has a 50-50 chance of it impairing pronation, supination, because that's what the radial head is involved in. It's involved in forearm rotation, pronation and supination. So this is the surgeon explaining this case to me. I didn't see him in emerge, and I didn't see him in a follow-up, but this is the pearl. These are the pearls that the orthopods offer me. And he says, as an 11-year-old kid, kids heal faster than adults do. So by the time the surgeon sees him 10 days later, the kid's laid down callus, whether you see it on an x-ray or not. And therefore, if it's starting to heal at 10 days, there's natural healing that's going on. If he tries to do a closed reduction on day 10 or 11, the weak link in the chain may not be the fracture because the fracture is healed. The weak link in the chain may be the growth plate. And therefore, this is too late for him to see it. He has to wait. And now when this child, they're going to let the child heal fully. And if he has impairment in pronation, supination, he may need an osteotomy, an open procedure of his elbow to realign this. But if the child was seen day 1, day 2, day 3, and it was realized that this fracture is not in an acceptable position, the surgeon could have pushed it up. However, he's not asking emerge to do the reduction. But this is the importance of asking the question, is the position acceptable? And if the answer is, I don't know, just call and ask. And you go to the surgeon, I got an 11-year-old kid with a displaced angulated radial neck fracture. I'm not sure if that position is acceptable or not. And then they can help you out. So these are little things that are helpful. So obtain and maintain, is the position acceptable? If you don't know, you need to find out. Okay, so he was immobilized properly, but this should have been reduced. This should have received a reduction, not by emerge, but by the surgeon. So again, how this mnemonic, this little memory aid helps. Here's another way it helps. Here's an 83-year-old who injures her elbow. She has a distal humerus fracture. If somebody asked you, what would you do with this? It looks pretty well aligned. Just remember one thing, never orthopedically make a decision with just a single x-ray. Always get 2 views at 90 degrees. Now, this looks like it's in a reasonably good position. The emerge doc, an excellent, a different emerge doc in our group, an excellent emerge doc, back slab, follow up with ortho. And if we just add that thing, obtain and maintain, that position looks relatively okay on the lateral film. But if you look on the AP, right, the position doesn't look, it looks a little bit off. There's a little bit of a step that you can see here where this is flipped over. So this is shortened. So this position is actually not acceptable. But now just say, do you think the fracture will shift? That means, is it a good or a bad fracture? There's 4 things we look at. Remember those 4 things? Is it comminuted? Well, there's one piece proximally, at least one piece distally, and there's certainly one big slip piece here. So it is comminuted. It's more than 2 pieces. Has it shifted? Well, we just showed you that it shifted. And does it go into the joint? Well, the joint is the elbow. It's hard to know if that goes in the joint there. On the other view, you can't say for sure. So not definitively it goes in the joint, but it's maybe suspicious whether it does. And then is it oblique or spiral? And yeah, you can see that that's clearly an oblique fragment. So it's got 3 of the pieces. It's comminuted, it's oblique, it's shifted. This is a very unstable injury. What do you expect it to happen? You expect it to shift over time. So even in a back slab, when it comes back on day 7, this is shifted predictably. And then I was assisting in the OR, and the surgeon basically said, that's predictable in emerge. This lady didn't have to have a week of pain. It would have been nice to know about it. We could have gotten her fixed much sooner. So again, another way that this your disposition skills will improve just by saying the phrase obtain and maintain. Now, when do patients need to be seen? So this is the last little piece of it. There are some true orthopedic emergencies. So high energy pelvic fractures, MVCs, that sort of stuff, absolutely can bleed. And those are middle of the night calls to ortho. The 80-year-old who fell and has a superior ramus, inferior ramus fracture, those are not a middle of the night call to ortho. If there's vascular compromise associated, of course, you'll be calling them. If there's compartment syndrome that you suspect, right? We'll talk about this in detail during the course. Infection. So if it's a septic joint and the patient is in shock, then yes, you're going to be calling ortho. If it's a septic joint and they actually are systemically well, you can wait until the morning. If you think they have neck fascia, if it's a significant open fracture, not just any break in the skin, but a significant open fracture where there's more damage to it, then by all means, so you have to give antibiotics as fast as you can. That's super important. And then significant open fractures should be called in the middle of the night, and ortho can tell you how they want to manage it. If there's a displaced fracture that you can't or are unable to reduce, and there's a neuro deficit, you can't leave that overnight. So a supracondylar fracture in a child, which you should not reduce, that's one for sure. If there's a neuro deficit, you're calling. I mean, for a supracondylar, anyways, if it's badly displaced in a kid, you're calling at 3 a.m. anyways. That's one of those particular fractures that are closed, neurovascularly intact. But if there's a neuro deficit, let's say with some other fracture, you couldn't reduce it, and there's a deficit, then somebody needs to get on that. If they have a neuro deficit but the fracture's in good position, ortho should know about it, but they don't need to be called in the middle of the night because there's nothing for them to do if the position's good and it never shifted. Urgency. So if you have so these are cases that you should let ortho know about at a reasonable hour, but you don't have to call them in the middle of the night. So a minor open fracture, let them know and they'll plan it. If you see somebody with a distal radius or any kind of fracture you think needs operative treatment, most of those can wait a reasonable hour and just have ortho figure it out. Sometimes we'll send patients home and say, listen, I sent them home overnight. I'll call them ortho in the morning and say, when do you want to see them? And then we'll have a follow-up call. Just make sure you get the patient's phone number correct. Again, there's multiple ways to approach that depending on where you work. And then if they have a septic joint but are systemically well, again, we'll talk about septic joints in more detail during the course, but as a general rule, these patients with suspected septic joints should not get antibiotics until the fluid's been tapped off, because you can actually, we want to know what is the bug that causes the infection. That's what surgeons and infectious disease specialists want to know. And if we give antibiotics beforehand, we can actually sterilize the culture. So it still has 90,000 white cells, but we don't know, it doesn't grow anything because antibiotics were given before the culture was done. So that's an important thing to try to hold off on antibiotics. So with open fractures, you cannot give antibiotics fast enough. With septic joints, if they're systemically well, you should withhold antibiotics until the fluid is tapped off. And then some cases, like the majority of cases, just follow up with ortho, and then that obtain and maintain, right? How worried are you about it? If it got reduced, you're more worried. If it's less stable, you're more worried. And this guides when they get followed up. And there are some cases where they're benign, relatively benign fractures, a base of the fifth metatarsal fracture, which if you're a rural physician, you may not need to send it to an orthopedic surgeon. It all depends on where you practice. And what you're guided by is this whole phrase of obtain and maintain. Now you're going to stratify. So what we want is at the end of the course, we want you to be better diagnostically, and you will be. We want you to be better procedurally, and you will be. And we want you to have better disposition skills. Not only better disposition skills, I think you'll have better disposition. You'll enjoy your work more because this is a big part of what we do. And again, the goal is not for you to memorize it, but to understand it. So if we make mistakes in ortho, like it's common from an emerge point of view, it's the most common mistakes are made in orthopedically. I don't want to harp on the mistakes. I want to let you know that we're going to make you better. Not perfect, but better. And these misdiagnoses, you're going to understand them. Mismanagement, you're going to be able to ask questions properly. Disposition, you're going to be able to stratify patients to understand how worried you are about them. The schedule, so what we're going to do is we're going to go through cases. Again, it's modular based, and when we get into the case, into the course. So commonly mismanaged. We'll do physical exam, we'll do demos. If it's the online component that you're getting, we'll put these in modules, and then we'll go on to the next one. If it's the in-person course that you're getting, then what we'll do is during the in-person part, we'll actually do the hands-on at this time. For day one, we cover up to the elbow, and you'll see the detail we go through. You will be so much better at the end of the course, I promise you. At day two, we go from humerus and finish off the lower extremity. So again, if it's an in-person course that's being provided to you, it'll be done safely, and the hands-on component will be incorporated in that. If it's a online course, if it starts online because of the coronavirus, and we're going to come afterwards for a day, this bonus day 3, then on that third day, we'll do some review lectures, just quick little reviews to remind you of the spectrum of injuries. Then we'll do demonstrations again, so you'll see them, and then you'll get hands-on practice. And when that'll be after the course, just when it's safe. So after you do the online component, once it's safe, we'll come to the host city and we'll do it again. Again, the concept of spaced repetition. We want you to rethink emerge ortho so that you'll take a patient with a normal x-ray and recognize it's surgical. You'll take a patient with a distal radius fracture and know it needs a reduction. You'll take a child with a radial neck fracture and question whether this position is acceptable or not. I promise you again, you will be much better after the course with your emerge. No matter where you are in the ortho spectrum, if you think if you're really good right now, we'll make you better. If you're just starting out, we'll make you better. I promise you. The course will get you there. And these are all pearls from our surgeons. We just put the emerge filter on them for you. How are you going to be able to maximize your benefit from the course? Plan to come well rested. So if you're flying into a course, which often happens, patients will fly to our courses. If you fly in, don't try to get a flight that comes in at 11 o'clock at night. Take the day, come in, be well rested for the course. You're putting a fair bit of effort into attending the course. It's ideal to get the most benefit. If the course is being done in your home city, don't plan to work the evening into it. Maybe you do a morning shift if you want, but ideally, try to take a restful day beforehand. You'll get way more out of it. Pre-course, you've got the video now, you've seen it. Ideally, maybe the week before the course, just watch it again. And this will just remind you of these concepts. There's some pre-course review cases we ask you to do. You don't have to hand that in to us. That's just for if you do that early on, it basically highlights where your learning was. We're going to review the cases during the course. You're going to get a chance again to work them up on your own. And when you do that again, you may notice there's a change in what you've learned from before you signed up for when you signed up for the course to after day 1 of the course. And then when we highlight that, we want that to stick. So one of the ways for the learning to stick is for you to highlight it, you to feel good about what you learned. And this is, again, this pre-course review that we asked you to do with these cases is strictly for your benefit. The manual you would have flipped through parts of the first chapter as we went through this talk. Again, bring that with you to the course. People often will write notes down during the course. If you can flip through the manual, just get a look at it beforehand. That will also help you as we go through the cases. Again, it's this whole idea of spaced repetition. We appreciate that people are super busy and you can't take hours and hours and hours before you do the course. But this is a commitment of maybe a couple of hours, an hour for this video, 20 minutes for the cases, maybe an hour. So 2.5 hours of time pre-course. And I think you'll get maximum benefit from the course if you do these things. And there's a needs assessment. If you can just fill out that needs assessment, it's helpful. Helpful to us as faculty. It's also helpful to you, because if you say, what I need to work on is my reductions, I want to work on when to see ortho, kids' elbows, whatever it happens to be. Then, if you've identified this, when we talk about it at the course, it raises a little red flag to you that, hey, you should pay more attention because this is what you talked about that you needed. So it helps us as faculty to understand where your needs are. It also helps yourself to identify your own needs when they get reviewed at the course. We're really looking forward to meeting you at the course, whether it starts out online or in person. It will be a fun couple of days. It will be fun, I promise you. You will learn tons. It will be clinically relevant. It will be high yield. I promise you all of these. If you need to get in touch with us before the course, CASTED at nygh.on.ca. That's the email address for our admin office at North York General Hospital. So please connect with us through that if there's some issues around timing of the course, receipts, anything administrative, that sort of stuff. If there's anything about the course itself, content, any other questions you've got or concerns, feedback on this lecture, just fire off to me. That's my email address, aaron.sayal@utoronto.ca. We're really looking forward to meeting you at the course in the coming few weeks. Thank you for listening to this. If you get a chance to catch it one more time, that would be awesome. Again, I think that'll help you with your benefit, but that'll help you maximize your benefit. But it's really going to be a fun experience hanging out and talking about Emerge Ortho. Thanks for listening. I hope you have a great day.